Phlegmatogenous retinal detachment is a well-known disease, and it is a potential cause of irreversible loss of vision. Retinal break allow ingress of the fluid from the vitreous cavity to the subretinal space, and the management was started like in 70 years ago by buckling. It's an external procedure that act to reduce the vitreoretinal traction, and we apply cryoablation to perform chorioretinal adhesion. By this technique, we can manage and treat subretinal fluid and subsequently dry the retinal detachment. In bullous RRDs, drainage of the subretinal fluid, they may need it. Then later in 70s, pars plana vitrectomy started. It's a different approach. This approach is internally and is based on removal of the vitreous body and BVD induction. Then we release the vitreoretinal traction by the occutome and shaving the retinal, the peripheral vitreous to avoid opposed vitreal traction. And we actively drain the subretinal fluid, and we are doing air fluid exchange. Then we create the adhesion by cryo or laser. And in this case, we implement a tamponade intraoculary that keep the eye or keep the retina in place. Then later, it's been more advanced. And in 2002, the small gauge pars plana vitrectomy become the most familiar procedure in treating retinal detachment these days. So what is the advantage of vitrectomy over buccal? It's number one, it is easy access to posterior breaks. This is one of the limitations of buccal. Buccal can work properly on anterior breaks, but the breaks have been intermediate or posterior, it's very limited for buccal. So vitrectomy works fine on this zone. And higher success rate in zodophakic patient. Disadvantages, it create cataract, induce more cataract. More oxygen in vitrectomized eye is believed to increase the process of nuclear sclerosis. Iatrogenic breaks can be created, 15% due to improper shaving of the anterior vitreous. And remember, if you didn't shave the vitreous and you didn't perform vitrectomy well, traction can be happening in opposite side to the previous break. BVR and epiretinal membrane is a well-recognized complication. So if I ask you, this is the question number one. If I ask you, an anesthetologist colleague approach you and you, as he's being diagnosed with retinal detachment, and the ophthalmologist offer him a retinal detachment repair with either scalar buccal or vitrectomy, what is your recommendation for him? Would you recommend for him buccal, vitrectomy, or none of the above? Can we vote? So it's been that clear, most of the staff or most of the audience, they go in the favor of buccal. Okay, now, let me ask, why you decide for that? Yeah, sure. Okay. Is zodophakic. Let's assume that. This is thank you for your comment. Your comment is very valid. So this information is lacked intentionally in the question. So we didn't mention this data because we want to clue that as more details you have, it will custom your management more. So we don't know, is he zodophakic? How old he is? Where is the break? How long is the procedure been? Or the diagnosis been? Did he did any procedure before? So we don't know. For this reason, we cannot know exactly what is the best procedure for him. Now, if we change, can we have the second question, please? If we change the scenario and we mention that 67 old male zoodophilic retinal detachment macula on with confirmed BVD on B scan, what is your best choice of treatment? Is it buckle or vitrectomy? We'll wait 1 minute, less than seconds till the question will come down. Yeah, it is there. You can vote. Can we have the answer, please? So now the picture is totally different. It's very clear that vitrectomy is the better choice for this case. Okay? So this is give us the clue that there is no single better answer always. It depends on the case scenario, so we can customize our management. Okay, back to the presentation. Okay, let's ask if it is possible to achieve internal procedure, intraocular procedure, without removing the vitreous, without the complication of vitrectomy. Is it possible? Yes or no? Yes or no? Random answer? Yes or no? Yes. How? Pneumatic. Yeah, fine. Pneumatic retinopexy. Okay. First described in 1980s as an alternative to vitrectomy and injection of expandable gas in the vitreous cavity that allows reabsorption of the subretinal fluid and cryo or photocoagulation will be done around the break. What is the advantage? It's an office-based, minimally invasive, simple, low cost. There is no anesthesia, no instrument, nothing. Air injection, then we'll do laser. It is less or no cataract progression, better physiological visual recovery. What is the limitation? What's the disadvantage? It's have a special criteria and indication. You cannot apply it for all of the patients, and it give good results only if selected properly, and less success than BBV as a primary procedure. The success rate of the vitrectomy is higher. So this is an example of one of the studies shows the uh, indication of pneumatic retinopexy. We can see single break or group of break in 1 clock hour. It should be superior, should not be in two spaces, and this should be given in certain type of patient. They should be cooperative patient, not in children. Those patients should be in doing proper positioning, and they need to come for frequent follow-up to do laser after the procedure. Yeah, no, exactly. Yeah. Uh, Question number 3. A 25-year friend of your brother approach you as being diagnosed with retinal detachment, and his ophthalmologist offer him retinal detachment repair with pneumatic, buckle, or vitrectomy. So, what is your recommendation for him? Check on our WhatsApp so we can, once the question is there, we can vote. Yeah, it's there. And the result? So now, again, we are just stressing on the same point. When you have consultation from your friend by phone about his case or his colleague or brother case, you cannot judge unless you have the full data. Okay? So this is young patient with fresh RD, and the doctor he offer him the full procedure. So there is mostly there is indication for this procedure all. So but you don't know what is the limitation. Is he traveling by airplane? Can he positioning? Or he can frequently visit? Or this patient need to go back for work soon? So there is a lot of things we need to consider when we take the decision of the retinal detachment repair. This will take us to the point that although there is certain clinical scenario may dictate particular surgical approach over another, but optimal management are controversy. Surgeon experience and patient condition can play a crucial role in this decision, and there is no absolute best procedure. Okay, now let's think in different way. If we have a procedure that have the advantage of pneumatic and the advantage of vitrectomy together and can avoid some of the complication, would it be fine? Yes or no? Yeah, of course, yes. This paper is Kekesh paper that's been published about new technique in vitrectomy. They call it minimal interface vitrectomy for rheumatogenic retinal detachment. It's been published by the author is Dr. Mora, and it's a novel surgical technique of minimal vitreous removal under air, not under fluid. So the technique is limited sectorial vitrectomy around the break only and release the traction that causing the retinal detachment. There is no BVD induction, and then we'll follow by endolaser or ablation. And then we put the tamponade. And they position in the article the patient for only 5 days. And this is a video that can show it is a small gauge vitrectomy 27, and they are searching now for the break or the breaks. With indentation, there was only one break. Yeah, of the endo, and the quality of the video really is not that good. I asked the author if he can have a better quality of video, but unfortunately, this is the best. Now, this is the cutter. Vitrectomy started under air, not under fluid. And they directed toward the brake. And you can see the brake on the right side of the picture, of the video. I wish we can show it there. Yeah. Yeah, it's here. Yeah. Yeah, it's there. Huh? So they release all the traction around the brake with active vitrectomy, aspirating the subretinal fluid. So the retina it's different from the pneumatic that retina will become flat inside the procedure. In pneumatic, we flush gas and we wait for the gas to push the fluid out. But in this, it is a controlled condition. Yeah, will pushed out. RB, yeah. Thank you. Now, after the end of the procedure, they will take bulk of the vitreous to allow space for the intraocular tamponade. Now, if you can note, there is cryo, and cryo scar is there. See the effect of the cryo? And some of the cases they treated by indolaser. Done. That's it. So the selection criteria for those cases was it's a primary procedure, single break, superior, young phakic patient, and grade B BVR at maximum. And the result was interesting. They did 12 eyes, and the average surgical time is by seconds, is not by minutes. It's the maximum procedure was 300 seconds. The average post-op IUB was 12, and there is no glaucoma and no cataract progression after 1 year follow-up, and the success rate was 100%. So we can say this, the advantage of such procedure, that it is a controlled condition. So you control all the condition in this procedure. You remove the traction, aspirate the fluid. On spot, we do cryo or laser, then we tamponade the intraocular gas. And then we actively absorb, and then we treat the retinal break, and when minimum removal of the body lower the risk of new break formation. This is what makes this more advantage on pneumatic, because if you keep the bulk of the vitreous as it is push upward, it will push vitreous from downward. So it may create breaks. And it's minimally invasive, and there is minimal post-op inflammation, less cataract progression, and the important thing, there is no change in refractive power. We face in our daily practice and a problem with retinal detachment on those young patients after LASIK or with ICL. If we do buckle, they will be in myopic shift. If we do vitrectomy, they will develop nuclear sclerosis. The advantage of such procedure, that it will not alter their refractive power. Any procedure have a limitation. The limitation here is it is costly because you open vitrectomy cassette, and the data is not enough because the sample was small and no control group. And in this case, success as pneumatic, if we good selected the cases, you may have the good results. And finally, I want to show you some cases that done outside this study in Kekish, and the house have been resolved. This is 45 phakic patient with superior RRD, and you can see pre-op on the right side, superior RRD with large break, and this is in post-op with this procedure. And this case scenario, this patient was with peripheral retinal break after barrage laser. Then it been extended and treated by pneumatic retinopexy. Pneumatic retinopexy failed, and the patient taken to OR and treated by this minimal interface vitrectomy. And from the first procedure, we can see that the retina is flat. And you can see even the laser is more anterior to the barrage laser, because all this detached area become flat. تفضل. تفضل. I think it's an artifact. I think it's an artifact. Yeah, I think it's an artifact. No, I know it's not related to the procedure, because the pathology was in superior. Okay, take home message. RRD is a sight-threatening condition, many surgical management option, no absolute best treatment, customized management based on case characteristics, patient choice, and surgeon preference. Thank you.
Bismillah. Yes, thank you very much, Dr. Ramzi. Nice topic, and trying to get rid of many complications of the vitrectomy. As okay, any procedure has its own inherent complications. The minimal interface vitrectomy, I think most of these cases they can be managed by pneumatic retinopexy alone. And we have done the first pneumatic retinopexy study here in 1988. And in fact, the beauty about the pneumatic is that failed pneumatics, you can go and do buccal or vitrectomies. And we found that they don't increase the incidence of PVR or otherwise. And the thing that a gimmick now we are coming to of pneumatic is that a slow absorption of the subretinal fluid will bring the retina anatomically to its almost to its place, and even the interdigitation. So that's why the visual acuity is little better than the vitrectomy. Now with this dry, true that we cannot get rid of all the fluids. The posterior part, there might be some fluid, but also this might sort of defeat some of the nice things about vitrectomy. Maybe this is good when you have a larger break, and this is with vitrectomy, especially when first injecting this, we will have fish eggs, and fish eggs, this can go subretinal, and probably with a controlled maneuvering of these, and letting the bubbles coalesce before even they approach the break area, this probably an advantage, so to speak. But most of the cases, I think superior breaks, these are ideal for regular pneumatic. Plus the fact that also pneumatic we can do on the table cryo as well, and no need for post-op laser. And this is in a difficult sort of uncooperative patient, or sometimes the patients will not undergo the hassle of laser through the gas. Sometimes we tilt the head, and but cryo over the intraoperative is good. But which is the downside of cryo, that it liberates pigments and RPEs, and this might go down. And we think that along with monocytes, they can sort of increase the rate of PVR, which is not proven very much in really large studies.
Thank you. And I agree that it's. I believe that this technique can fill a gap between the pneumatic and the vitrectomy. And if the patient can fit for pneumatic, it will be better because it's cheaper and easier. And in some cases, I we tried this case with this procedure on top of failed buckets. It works fine. So it can be extended. It didn't been studied well, but it can be extended in indication to even as a secondary procedure after failed pneumatic or failed bucket.
Failed buckle also, especially where the positioning of the buckle is not 100% over the brake. Also, we can augment it by pneumatic. Very
Pneumatic,
easy.
yes.
Just injection of air, even not gas. It will fill the gap. Probably better still than the endo. I told you, I commented earlier, is the chandelier light, so that you will not have this movement in vitreous gel, which in fact can have sort of traction on the peripheral retinas elsewhere.
Yes.
And you see that no always that they say new brakes in pneumatic, probably we always label it as new slash missed brakes. And some of these are really missed because sometimes the inferior part, there is vitreous hemorrhage. We couldn't really see very well preoperative. And then we discovered this. So now I'm yet to see a real new brake from pneumatic, to tell you the truth, because the bubble is so small and it enlarges with time. And that's why probably there will be, but I'm waiting to see a new break, real new break. But some of them are really missed breaks because of opacities in the media during preoperative evaluation.
Thank you. Thank you. Dr. Hassan?
Thank you, Dr. Ramzi, for this great, presentations about such issues that we are facing that all the times. But I think so going with pneumatic retinopexy or interface, vitrectomy for such situation, it depends in the situations that you face. Sometimes when I'm going for vitrectomy, 20 something gauge, vitrectomy for such case, so that make minimally invasive, it is costing in the same time.
Yes.
So we have to put all this together. The pathology that you are facing, single, tear, usually it can be managed. And this is usually mostly pseudophakic patient or something like. But in most of our patients that myopes or advanced pathology, usually it is too difficult to go with all this type of procedure. We need to be a little bit aggressive in our management, otherwise we'll end it by BVR, and then are difficulties to fix this retinas. But I think there is a rooms for certain patient when there is systemic issues with this patient cannot go for OR directly, where you can go with pneumatic retinomyxy. You can add it with, unless you are doing your small gauge 27 in the minor OR, which is under topical medications. It can be. Otherwise, I think so. It is too difficult to apply it for all the patients.
No, no, no. You cannot apply this for all the patients because it has for selected cases. So this is the point that the message we will deliver, that it should be for the selected cases. And if you apply it for all the cases, it's not justified, because some cases will be doing very fine with bars plana vitrectomy.
And I'm finding that even nowadays with the chandelier light,
Buckle,
buckle, it's
yes,
usually it's
yeah,
very more effective than
sure,
just putting your
definitely,
indirect and
yes.
looking for the. In addition to what we have as wide field, fundus photos, usually helpful to see something that cannot be seen with
Totally
uncooperative
agree.
patients.
Yeah, Dr. Assan.
I thank you. Thank you, Dr. Ramzi. It was very nice. I like the fact that you made it interactive so that people, keep their attention. It was very nice. I don't understand honestly the advantage of this, different technique, this new invention of doing this interface vitrectomy. I'm just like Dr. Amro. I cringed as soon as I saw the probe moving in, solid gel from one area to another area. I came, cringed really, because once you invade the vitreous, and if you don't remove it, I mean, one of the things that we teach is that when you do a vitrectomy, you prefer not to do just the core vitrectomy. You do a vitrectomy and you try to peel the hyaloid so that you avoid the future traction, which is caused by the hypocellular vitreous contraction. This is known. The hypocellular vitreous contraction is what causes the problems down the line. So I don't really see the advantage of it. If there was a break that was seen, I don't see the advantage of just going next to it to remove the vitreous. Just next to it, that can be done with a sponge. That can be done, if there's a lot of traction from the outside, you can do a sponge. You can do even, a temporary sponge, just like a link of balloon. You can put a sponge there to create the adhesion, to remove the traction, create a proper seal with cryo or with the laser, preferably with laser if you don't want to seed so many, RPE cells. And then eventually, if there is a refractive error, remove that external element, that should do it. So I think if you put all the questions that you had without giving all that information, I think I would go for buccal for every single answer. For that, if I didn't have any more information, I think buccal is the one that's going to not require you to say where the break is, because it would work for all breaks up and down and right and left, right? Unless they're very posterior, of course. If they're very posterior, that will not work. But you don't care about if the break is inferior or up, because pneumatic, it has to be up, and with a buccal it can be down. And in a pseudofake, you can, if you see very well, if they have a clear capsule, there is no reason why you cannot do a buccal, right? But the reason we do a vitrectomy in a pseudofake is because sometimes the capsule does not allow us to see very well, so we may miss breaks and we cannot do them with buccal. So and pneumatic in selected cases, young people with no PVR at all, and really between 3 and 9, and not between 8 and 4 is, I think, is very, very reasonable. And during the buccal, if you want to, you think that you cannot really carry it very well, or you need an extra push, you can always inject a little bit of air during the buccal procedure. Then it becomes an intraocular procedure, but then you can get that extra tamponade. So I think that the follow-up was only 1 year for those patients, that 12 patients that were done. And I'm very scared about something like that. So I don't. Yeah.
Also
But thank you.
The principle of, as you mentioned, that the principle of this procedure is breaching the main principle of vitrectomy, is to remove the bulk of the vitreous, induction of BVD, and do peripheral shaving. But it's something that being tried and it works in some cases. So it can fill some gap in some area, but you cannot expedite it on all our patients. It
For
may not,
sure.
yeah, definitely.
And there was no control group. I mean, probably just doing just a vitrectomy in those
Yeah,
cases, or just a pneumatic, or
yeah.
just a buckle
May it
would
works.
have also worked
Yes,
100%.
that's fine.
Yeah, yeah.
Yeah, true.
Because they were simple cases. There are single breaks
Sure.
with not a lot of PVR. So I don't see the
Yeah.
rationale. But thank you very much. It was very nice.
And again, just stressing on a message that any procedure that we learn in our life, it's like a weapon that we need it in one day in our practice. تفضل دكتور.
Yeah. طبعا if you don't mind, because
تفضل
of this,
تفضل.
we looked for the shift from the sacral buckle to vitrectomy over the years, last. And it was found just in the last in 2022 that most of the procedure now is done for the for buckle for that acute retinal detachment is towards 90% for vitrectomy. So there is a trend,
It's
shift
true.
for all the young, generations
Generations
regarding to that.
toward
And not only in that, it is based on the single, surgery success rate, which is mostly depending on the functional and anatomical success. It was found almost comparable. Although I was against that to go with buckle, but this is now the trends internationally. So that improvement in the vitrectomy machines, small gauge, and how much we can clean up the vitreous at the peripheral, making vitrectomy is less invasive when you compare it with the past, and even though comparable to the buckle success.
تفضل.
I have a comment here.
Thank
So,
you very much, Dr. Ramzi. I was planning to join vitreoretinal specialty at one stage, and I scrubbed with Professor Amr. We started 7:30, we ended 1:30. That day it was my day to make decision not to join the vitreoretinal. I think, I don't know, but one of the area in ophthalmology that it has a lot of challenges is the vitreoretinal surgery. The retina will get breaks either due to congenital weakness or traction, and the break is a relaxing mechanism that's happening within the intraocular space. Is there is a potential to use a graft with an internal grafting to the retina to leave the retina under the same relaxing stage, aspirate the fluid from the subretinal space, and put a graft to that area. The scleral buckle, as mentioned by Dr. Sausan, is excellent, but I think it is still a foreign body that sometimes it's exposed, infected, and so on. I'd like to know, because now we are created the invention door for our staff. I think there's a high potential to create certain new procedure that will be linked to KKH staff in the future. Maybe Professor Amro and yourself and other staff shed light on that. I didn't know if there is anything for retinal graft. I'm expecting tomorrow we will find that Muhammad al-Mutlaq is requesting retinal tissue for grafting.
Now we as you know, we have also now grafts for macular hose, and also there is research on graft on peripheral hose as well. We have, in fact, there are, and also there are tissues to glue over the breaks as well. So now things are moving, but the main issue is that I think the best thing is to try to prevent retinal detachment, and with the lysis of the vitreous, especially if there are tractions on the peripheral vitreous space, and this is the main question. Now back to when we have scleral buckles and we do chandelier, or even we do external subretinal fluid drainage, we transfer an extraocular procedure to an intraocular procedure, and this is an issue, true, but if we can do non-drainage scleral buckles, this is all extraocular, and this is, I think, we try to use, and this is a big gimmick versus even pneumatic and vitrectomy as well.
Viscoelastic could be injected through the suprachoroidal space to seal the breaks. Yeah, just temporary, and can be helpful as well, not just only to put some transplant or viscoelastic material just only the suprachoroidal space at the area of the breaks for temporary times when doing your cryo and leave it so that you don't need even though any material to be used for a buckle. Yeah.
Yeah, I think what if Dr. Zisper wants to have linked, new Kekish procedures linked to Kekish, I think a revival of the concept of the linked balloon is the way to go.
It has been. Yeah,
I know,
got
but
it.
it's a
No, I
revival.
mean,
Do it in a way that
They put tags, tagged,
no, no. The idea is, actually, thank you, Dr. Ramzi, for the topic. It opens very good discussion. So there is a lot of room for improvement in retinal detachment repair surgery in general. And this is one of the techniques that were thought of. There is another by Rajiv Moni where they described minimal gas vitrectomy in order to achieve retinal reattachment with a small gas bubble and not to cause retinal displacement. Now, the least procedure to reattach the retina with the least percentage of retinal displacement is pneumatic retinopexy. Now, I believe that pneumatic retinopexy is underutilized at KKH. And this is the same as what happens in many hospitals, eye hospitals around the world. So it is a culture of the hospital. Probably part of it is the teaching and or the experience, and the second part is, in my opinion, the way that the on-call runs. So if you get a retinal detachment early in the on-call, then you have time to attempt pneumatic retinopexy. If it fails, then you can do it. You can do vitrectomy in the same week of your on-call, and you will not. But if it is at the end of your on-call, then you are stuck, and this reduces the number of patients that we do pneumatic for. Now, are we disservicing our patients by not doing pneumatic? In my opinion, if you go ahead and do vitrectomy or a scleral buckle in a patient who is a candidate for pneumatic and you don't do it, then I think, in my opinion, that yes, we did not do the best procedure to the patient for his particular form of retinal detachment. So I think maybe since the administration is here, I think maybe there is a revisit of the change of the on-call system in the hospital so we can accommodate and properly manage more patients during the on-call of the staff, rather than trying to select the the procedure that will give you the highest single success, but may not be the best procedure for visual acuity outcomes at the end. Part of it is culture. Bascom Palmer, they don't do pneumatic, but we should not follow the same. I think pneumatic has regained popularity again now, and it
I
should be
totally
done.
agree that we do less pneumatic than we should do, but we need to look to the whole picture. And as you know that our patients, most of them, they are not from the Riyadh. To stay here and to come and go to check for the gas bubble, to do more laser. Also, this is a factor that affect follow-up, and you are busy in the on-call, you cannot give appointment. I agree with you, but the picture, we need to look to the picture in comprehensive way. Yeah, we do much less pneumatic as indicated. I agree totally for that. And if we can do pneumatic in the office, I think it will be very helpful for minimize or decrease the number of uh, patients they go for general anesthesia, especially for young patients. So we can do pneumatics in the office, and they can bring him to the clinic or to our laser clinic in 1 or 2 days to follow up with him. I totally agree on your point.
Yeah, for the sake of discussion here, I just there was some paper I also commented to Ramzi here. There was a doctor who studied if you come to the clinic with a retinal detachment, it depends of the day. So Monday, Friday here. So which is the chances? There is a day you have more chances to get pneumatic retinopexy. Yes, it is. You come on Friday at the clinic,
Friday,
you get pneumatic.
Yes.
And it's been studied. And also, not only that. So this study also, what happened with this patient, they receive pneumatic retinopexy. They get twice the chance to be reoperated in the following week. So, I mean, I know that I know very well the work of Tribe Jitsuni, and honestly, I think it's a very nice job here. But I'm not really a great fan of pneumatic retinopexy. I'm probably more because I got my culture from Europe. And in Europe, it doesn't matter how you treat the retinal detachment. You don't have to pay because public hospitals don't charge the patient. So there is no interest to do pneumatic or either buccal or either vitrectomy. Most of the centers in Europe, they're doing vitrectomy for doing these cases here. Why? Because you have an easy case, you have to get the best outcome, you got to solve the problem here. You put pneumatic, and it becomes worse, and then you don't have the OR here, so we'll be in trouble. So that's why probably there is a cultural trend also about how we do it here. And when we compare our patients to American patients do much more buccal and pneumatic than us. Why? Because for them, the cost of the surgery is an issue. But in Europe, because probably most of the patients are treated in public hospitals, they don't charge the patient. And that's probably what's also because it depends on the training of the doctor here. I agree that the doctors should be trained in pneumatic, of course, but they should train it also in buccals. Why? Because buccals, for some patients, they do a great job. And if you are only one system to fix the retinal detachment, or you only know how to do vitrectomies, you will be in trouble. Because under the cases, especially pediatric cases, they do much better with the buccal. So you must be training the 3 tools and use the tool on the right way with the patients. Because my question about that is, let's see, you have this limited vitrectomy, and you have a redetachment, you have a new break. So it happens a break treated, you have a final new break here. How you should proceed into that?
If you develop a new break, so it's better to switch to another procedure. So we'll do buccal, for example, or you'll do full vitrectomy for that patient. And as you mentioned that if you have an experience to do multiple procedure, so you have different tools to manage your situation. I remember one story that during COVID lockdown, I was in charge for retina division in Jeddah hospital. So I receive a call from one colleague. He's having RD macula on, and he doesn't have cassettes. He said, okay, send me one cassette. I said, what system you are on? He said, I'm on Stellaris. I said, no, I'm working on Constellation. I said, okay, just do pneumatic. He said, I don't have gas. I have only silicone oil. I said, okay, what do you think? He said, do you have bands? I said, yes, we have. Okay, send me, I have suture. Send me bands. So I sent him bands, and he did buccal for the patient. So I like the way he approached this situation. He can do pneumatics, but he doesn't have gas. He can do vitrectomy, but he doesn't have cassettes. And he can do buccal successfully to treat RD macula on in lockdown. So this is what I want to say in real life practice. If you have the skill to do more procedure, so you have the chance to solve in real life practice more troubles. Thank you.
Thank you, Dr. Ramzi, and for actually my mentors who participate in this. So I have 2 comments. The first comment is regarding pneumatic retinopexy. We know that pneumatic retinopexy, if done on appropriate patients, it provides better vision for them and better retinal reattachment. But the issue is that, is this the best surgery or the best intervention for the patient? Because we know that our experience with pneumatic is not as our experience in other interventions, for example, vitrectomy and scleral buccal. So it might not be the best, intervention for the patient unless the surgeon is experienced and know how to do them. So when we are experiencing pneumatic retinopexy and we are doing it for many patients, here comes the second comment, which is about the minimal invasive interface vitrectomy, because the only, in my opinion, the only indication for this type of surgery is that if you want really to do pneumatic, but you cannot do pneumatic because of media opacity. So let's say a patient comes with vitreous hemorrhage and retinal detachment, and this retinal detachment is associated with a break that comes in the criteria for pneumatic, but I cannot do it because of the vitreous hemorrhage. Then I can do the minimal invasive interface vitrectomy and put gas. Other than this, if I'm going with the trocars, then I will do full vitrectomy. If I'm going with pneumatic, I will do pneumatic.
Thank you. تفضل.
The pneumatic retinopexy, you don't have a long learning curve, because this is all what, if you master indirect ophthalmoscopy, you can do it and do it. And there is no sort of experience or skills that are out of the scope of even an advanced resident, in fact. So probably no need for experience in pneumatics. Patient selection is important. In fact, I lean to superior 2/3 rather than 1/2 of the circumference of the retina. But I don't think they are not to do, because we lack sort of experience of in the pneumatic, because once you do, even without cryo, you only inject. And once the first publication of pneumatic by Helton, he said that management of retinal detachment without conjunctival incision in the office, and this is the beauty of pneumatic. And once, if you know indirect, I think you can do a decent pneumatic retinopexy for any patients, even from the first trial as well.
Yeah, I agree. But sometimes when you read articles and see videos, it's not like when you are faced with patients that you know that you can fix it very easily with buccal or vitrectomy, but you are not that confident with the pneumatic. It's difficult sometimes to go with the pneumatic, especially that you know that within 2 to 3 days that you will not be having an OR slot for this patient if this fails, because still I, and maybe I'm talking about my colleagues in my age, we are not that experienced and we are not that confident with pneumatic, although it is practically, it looks easy. But when I put a gas bubble and then the patient does not do it, and then this retinal attachment extends, and then I'm having difficulty with doing laser under gas. And so there are some difficulties that will prevent me at least from going to do pneumatic at first. And again, if I'm having OR slot tomorrow and I'm faced with a patient with a superior retinal detachment, macula on, I will do him tomorrow in OR vitrectomy or buccal or whatever the case is. But again, if I don't have an OR slot in 2 or 3 days, then most likely I will go with the other surgeries, not pneumatic. But I agree with you. So we need to do more pneumatics. So we need to push on ourselves to do more pneumatics so that we get experience. So we don't get experience while we are not doing cases.
Yeah, the main thing is the injection of gas. Once you just know and master little tricks, and so that you will not have gas escape from the wound, and just tell the patient so that the gas will go to the other side. Otherwise, all is done by the internal tamponade of the gas itself. And otherwise, then if the laser through gas or repositioning of the head to uncover the break is a little difficult, one can do just probably 1 or 2 spots of cryo intraoperative, and this is not a difficult issue.
Patient that could be candidate for pneumatic retinopexy, and they asked the whole of the surgeons, which is the opinion here. So almost 80% of the patients they do vitrectomy. So as I think what I like about the lecture of Dr. Ramzi is the highlights that it depends of the case, it depends of the patient, and it depends on surgeon training. Because when we talk about surgery, I really don't like to put in general questions. It depends on your training. If you are good trained in buckles, do buckles. You will do much better. They try to do a vitrectomy, you don't know how to do it here. If you are trained in normal retinopexy, do it.
All the areas, and they're getting some survey from Taiwan, from China, and from America, and they found that the trend is going to vitrectomy because maybe people they don't have enough training for the buckle before.
I think you will enjoy it. The patient the next day doesn't have the air bubble, doesn't have the gas bubble. The eye is quiet. The media is super clear, and the patient can see because the RPE takes care of a lot of things. And then, and you know, if you do a non drainage surgery, you do a buckle, and to decrease the pressure in the eye, you may just do a paracentesis, for instance, just to be able to put your buckle comfortably and leave the fluid. The next day, the retina will settle just like with pneumatic retinopexy in its original place, and the patient does see better, and you see better, and you know that if the fluid is gone or mostly gone, that you've done it. It's a one-shot go. So the thing is, I think, again, is you have to know, and that comes with experience, you have to do the minimum surgery that gets the job done. And the minimum surgery that gets the job done can be as simple as injecting a gas bubble or as applying a little bit of laser and around the very limited detachment, or all the way to a complete vitrectomy with buckling, with peeling, with everything, because that's what the eye needs. So if you do a minimum surgery in a patient who has PVR, that doesn't work, right? But if you do an extensive surgery with vitrectomy and silicone oil because you don't have gas in a patient who did not need it, then that is a disservice, like Dr. Sleiman was said. So we need to do the minimum surgery that gets the job done for that particular case.
Okay.
Thank you very much, Dr. Ramzi. I really enjoed your lecture. Thank you so much.
Thank you. Thank you to all.